neurometabolic disorders of the newborn. As I went to Johns Hopkins in 2007, in October 2007, I was lucky to have a team around me from the neonatal intensive care nursery unit who said we have to work together to combine all our brain power and all resources to take the care of all those children who come to our hospital who have suffered from hypoxic ischemic injury. And we meet once a week and we go over all the imaging data, we discuss it, and we are either very proud of a child who's doing very well, or we're devastated because whatever we did, we worked so hard and it didn't go very well. It is a very rewarding group, but on the other hand, what I also see frequently is that we have so-called characteristic imaging findings, and we saw this morning being presented by my colleague Eileen Tekesh, which are so straightforward to say this is an hypoxic ischemic injury most likely. Or we say this looks like an hypoxic ischemic injury, and then the clinical team says, yeah, but there was no hypoxic ischemic event. So what Zoltan just said, there are sometimes you see imaging findings which maybe look like HIE, but they are not HIE, or the other way around, and it is very essential that we are aware that not always everything which looks like HIE is HIE. And then I asked one of my friends, Andrea Rossi, who is from Genova, I said, how do you solve it in your institution? And he said, we don't have that many cases. He said, but it's a good idea. Why don't you prepare a talk about neurometabolic disorders of the newborn? So if you ask, sometimes you end up in trouble yourself. So what I want to do here is I worked and thought about putting the literature together and to find out which kind of metabolic disorders can already present in the immediate neonatal time period, because we should not miss those. And if we maybe would use a treatment which is designed for an hypoxic ischemic injury on a child with a metabolic disorder, maybe we induce significant brain injury. Or if we don't do it because we think it's a metabolic disorder, then maybe we have missed the chance of saving or limiting the degree of injury to that brain. What I want to do is go briefly about how important it is that you are aware of how neurometabolic disorder or metabolic disorder in neonate can present, and then basically go over a couple of cases to show it to you what you can see some of the differential diagnosis. Now, in the meantime, most of the cases I'm going to show you have been shown today in the various lectures, so it should be very straightforward and have, again, nothing to disclose. So, what is important about disorders of metabolism in the immediate neonatal time period is they are individual, they may be rare, but in total they are numerous. The other big issue is that the early symptoms are usually very non-specific, so they really do not help us very well. And predominantly, what is the major problem is that they may mimic other so much more common, so much more frequent, so much more well-known, or by clinician more recognizable diseases, like in hypoxic ischemic encephalopathy or hypoxic ischemic injury, or in neonatal sepsis, or even maybe something like in congenital heart disease. Now, we should not forget that many, not all, but many of these neurometabolic disorders in the neonatal time period can be treated, or at least we can limit the impact on the brain, the devastating impact on the brain. So a rapid diagnosis is essential to prevent or limit irreversible brain injury. But not only rapid and correct. And that's the difficult part of it, of course. Okay, whoops, the grant's too fast. So basically, this is the end of my talk, and many people do it like this. No, I'm not going to do it like that. The most essential fact is always think about disorder of metabolism if you see something funny happening with the brain which you can't explain. And as soon as a disorder of metabolism is suspected, you really should start the diagnostic workup and possibly also the treatment. You should not waste any time. So diagnostic plan and treatment options should basically be ready to go even prior to delivery in a couple of situations. Number one, if you are dealing with a family where already previous children or previous subject in the family are known with disorders of metabolism. So don't wait and to start again over. Just basically be ready to go. Also in those cases where you have an undiagnosed or not completely solved neonatal death, a previous pregnancy, always think about this could be a metabolic disorder and you don't want to end up with a repeat of the same. And if you have somewhere in the family or somewhere siblings who say there was a very severe illness in the immediate neonatal time period which was unexplained, so be prepared that this could be a metabolic disorder. Also be aware that the neonate has a very limited repertoire of responses to severe illnesses. We have discussed it this morning. Neonates usually present initially with these very non-specific symptoms, as I said before: respiratory distress, hypotonia, we saw the floppy baby of Dr. Tekish this morning, poor sucking, vomiting, diarrhea, dehydration, lethargy, and the very non-specific seizures. Now, all these symptoms are so easily being explained by clinicians as this is secondary to an hypoxic ischemic injury, maybe sepsis or the congenital heart disease. So you are every time at risk of getting on the wrong path. By the way, just a fact, metabolic disorders are rarely associated with prematurity, just to keep in the back of your head. Now, patterns and timing of presentation. Disorders of metabolism, inborn or acquired disorders of metabolism, may be present or may present already during pregnancy. For example, hiccups. The mother can tell this child or my fetus had a lot of periods of hiccups. Typically the mom will notice this. Or they may present at birth. Immediately at birth, the child has significant problems. Or this very devastating moment, or this devastating situation, the child is born, and 2 or 3 days later, it suddenly dies. Or you can have a symptom-free interval, which can be a couple of days, weeks, or even longer, and then the child starts to decline rapidly. These are the different patterns and also the temporal evolutions of presentation of neonates with a metabolic disorder. Do not forget that the placenta may act intrauterine as some kind of a dialysis station, because disorders of metabolism are typically present from conception on, and most defective enzymes are active in fetal life. Now, frequently, those metabolic disorders will not have devastating adverse effects on those fetuses which survive until the end of pregnancy, because the placenta takes out those toxic metabolites. So that's why those kids can be born in good condition, then start to decline. So placenta is important. Now, we saw this before, Zoltan showed this. How are you going to classify this disorder of metabolism? There are as many classifications as there is confusion in the world, and everybody would like to have his own classification. I just added another one. I took the classification shown by Zoltan, and basically it is disorders that give rise to intoxication, disorders involving energy metabolism, which we also discussed briefly before, disorders involving complex molecules, and disorders involving neurotransmitters. And this really helpful group, the various disorders. It always works, is it? Now, patterns of deterioration, 5 categories. Unexplained hyperglycemia, something which should be an alarming sign for maybe some metabolic disorders going on. Disorder of acid-base status, a rapid neurological deterioration which you can't explain by something which was happening during delivery. Cardiac disorders is important because those can be mitochondrial energy metabolism disorders, because not only the brain is involved, also the heart and the musculature can be involved, or those where you have acute parenchymal liver diseases. Okay. Let's look at some cases. Now, if your baby does this, you don't have to worry about metabolic disorders. Okay, so the first case I'm going to show you, one image was shown by Dr. Tekish this morning, so you should make the diagnosis in a split second. And this is not an inborn error of metabolism, but is one disorder of metabolism or something which is involving the metabolism which you should recognize immediately. This is a term neonate, and that's, by the way, why I put it in this talk. It was a normal delivery, vaginal delivery, the APGAR scores were unremarkable, and then the child started seizing significantly. So you think maybe there's a stroke, something like that, so you do imaging. And you all remember this imaging from this morning, a T2 and T1 weighted imaging. On first sight, maybe not that impressive. But if you look carefully, here you see the cortical ribbon very well defined, and here it is very ill defined. The differentiation between white and gray matter is obscured over here. And also in T1 weight imaging, there's some artifacts over here, unfortunately, but you do see that the gray-white matter interface here is less well defined as anteriorly, and maybe also the white matter is a little bit hyperintense, and also the corpus callosum here is too hyperintense. It's symmetrical. This is diffusion weighted imaging. On diffusion weighted imaging, on the DWI images, we see restricted diffusion affecting the cortex and subcortical white matter bilaterally in the parieto-occipital region, a little bit more on the left than on the right, also extending into the corpus callosum. We have an MR spectroscopy of the basal ganglia and the white matter. We see somewhat reduced N-acetyl aspartate, and at 1.3 ppm we see here some lactate both in the white matter as also in the central gray matter. So you know the diagnosis, correct? Is this a neonatal hypoxic ischemic injury? And I'm not going to show you this now anymore. Is this a neonatal hyperglycemia? Is this a neonatal metabolic stroke or injury? Is it a dural sinus thrombose because bilaterally occipital, or is this just neonatal meningitis? Now this is, of course, the neonatal hyperglycemia, which Dr. Tekish already showed you. Now what are some key factors which you should remember, which I will also ask in the SAM question, about the metabolism, what is the importance of glucose during metabolism? Glucose is the primary metabolic fuel of the brain. It's not oxygen. It is glucose. It's essentially important. The oxygen consumption is relatively low in the neonatal brain, interestingly. Now, concerning glucose, there is a lot of literature out there. What is the minimum amount of glucose you need in your blood to have an adequate metabolism? Now, this is not known. There is so much in literature, and nobody knows it really, and it depends so much on the demand. If you have a lot of seizure activity, you need more glucose. If you have an hypoxic ischemic injury, you need more glucose. So it's very unknown, unfortunately. What is interestingly is also that glucose is being recruited from the liver. So something has to be controlling how we recruit glucose from the liver, and this is most likely done by the brain. So if you injure the brain, you will most likely also impair your glucose recruitment. And also interestingly, and this is a very important statement for example, SAM question, glucose production in neonates is 2 to 3 times higher than that of the adult level if you compare it. Okay. The clinical presentation is important, as I said at the beginning. It may mimic a hypoxic ischemic injury, sepsis, neonatal encephalitis, and metabolic stroke. And what is most important, be aware, if you do not treat it, and it is so simple to treat it, you may induce irreversible injury, and nobody will be happy about that. There's a whole list of etiologies, and every textbook will show you neonatal hyperinsulinism or nesidioblastosis. I have never seen it in my daily life, maybe I missed it. It can be that you have diminished glycogen and lipid stores due to intrauterine malnutrition. You can have impaired gluconeogenesis, or you can have increased glucose use in HIE, sepsis, or congenital heart disease. We looked at the imaging findings before. This is a case from Tina Yang-Poussin. Because she's here, I put it in there to again to say thank you for your support. Typically, you have the involvement, cytotoxic edema in the parieto-occipital, gray matter, cortical gray matter, and subcortical white matter can result in superficial necrosis, restricted diffusion, as I said before. On MR spectroscopy, as shown, we have N-acetyl aspartate reduced, lactate increased, and on follow-up imaging, you can see an explicit parieto-occipital atrophy, while the remainder of the brain is rather well preserved. So if you see this and you have no clue about the history, just ask the clinician if there was maybe a history of a neonatal hyperglycemia, because this would explain it better than a classical hypoxic ischemic injury, pattern of injury. As briefly mentioned before, the mechanism how the brain regulates how the glucose is being recruited from the liver is unknown, neural or hormonal effectors. But it means that if the brain, for some reason, is malfunctioning, it will most likely also be linked to a disturbed glucose output of the liver, and that's why frequently you will have, on top of an hypoxic ischemic injury, a component of a hyperglycemic brain injury. Now, every neonatologist knows this, that they have to take care of the glucose level in the blood, so hopefully this will not happen, but it's important for you to know this. Now, some cases, another case, and you will make this diagnosis within a split second because you saw it today at least 2 times. 10-day-old girl with failure to thrive, poor feeding, vomiting, and increasingly lethargic. This is a classical metabolic disorder which you can see in the immediate neonatal for the first week of after delivery. On T2 weight imaging, what Zoltan already showed, a T2 hyperintensity symmetrically within the brainstem, within the mesencephalon, going up all the way along the cortical spinal tracts, and it is T2 hyperintense and it is swollen. It is following those areas of the brain which are very well myelinated. And it has a matching restricted diffusion on diffusion-weighted imaging, following here also the cortical spinal tracts into the centrum semiovale, very ADC hypointense. Those areas which are not yet myelinated are not affected. So what is your most likely diagnosis? Please, no HIE this time. Please, no hyperglycemia. I'm not going to show it 2 times. Metabolic stroke injury. Yes, that is something you have to put now in your primary differential. Dual sinus thrombosis and neonatal meningitis, still not correct. So it is some metabolic crisis, stroke happening over here. And of this list of metabolic disorders, Zellweger, Alexander's, maple syrup, urine disease, Leigh disease, adrenoleukodystrophy, this is the classical maple syrup urine disease. It's also known as leucine encephalopathy. It's an inherited autosomal recessive disorder involving the branched amino acid catabolism, and typically leucine, isoleucine, and valine are involved. And you get typically an accumulation of leucine and the metabolites, which will result in neurotoxic oxidative stress. And the increased leucine in the brain will result in brain, muscle, liver, and pancreatic edema because the cell volume regulation is impaired. That's why you see this hyper-intense signal along the myelinated parts of the brain. The patients typically present after a disease-free interval, this scary disease-free interval, 4 to 7 days. Patient already went home maybe, and then start to deteriorate, poor feeding, vomiting, is not gaining weight, become lethargic, gets back to the hospital, ketoacidosis, hyponatremia, and this may mimic sepsis again. It is known that breastfeeding may delay the presentation. So be aware of that, ask it, or the case you should ask it. Fever, increased catabolism, may induce an acute crisis or may accelerate it. Be aware of that too. And it is called maple syrup urine disease because apparently urine smells like maple syrup. And I have learned from Professor Boltzhauser, one pediatric neurologist who taught me that it is especially the cerumen in the ears which smell after maple syrup and not the urine. So it should be maple syrup cerumen disease. Okay. How do you diagnose it? Plasma detection of allo-isoleucine is diagnostic, and typically you have a rather favorable outcome if you have a lifelong strict dietary control, foods with or without or limited branched-chain amino acids, and always a very aggressive treatment of any kind of metabolic crisis, including just very, very straightforward infectious diseases. And here, what I said at the very beginning, if the family history is positive, you should be prepared to immediately start treatment, to start diagnosis, and then usually you will have an excellent or very good outcome. Imaging 5, we described it. The hyperintensity along those parts of the brain which are already myelinated, and you have typically restricted diffusion during an acute crisis. Another case, 80-year-old male presented at the ED with mental status changes. Talking nonsense, repeating himself over and over again. 2 days early, abdominal pain. Neurology, symmetric ataxia, diminished muscle bulk, dysmetria, ptosis, elevated protein CSF. Now, this child has had multiple episodes much earlier, already in the neonatal time period. That's why I showed this kid. This child had 4 years earlier and in the neonatal time period already episodes where suddenly it went downhill. In 4th grade, the child was doing okay, but had problems in gymnastics. Could not play soccer that well, had some issues. Now, what do we see on this? Not neonatal, but an imaging on a child who is having issues since the neonatal time period. We see T2 hyperintensity within the brainstem, the dorsal brainstem, mesencephalon, thalami, and here also within the central gray matter. No matching contrast enhancement. Now, which statement is correct? Is lesion distribution asymmetrical? No, it's symmetrical. Is the central gray matter predominantly involved, or the cortical gray matter is predominantly the central gray matter? The white matter appears rather spared. The globulopallidae, are they spared? Yes or no? Look at the imaging. Are the putaminae predominantly involved? Again, look at the imaging. So here, the central gray matter is predominantly involved. See here, also diffusion-weighted imaging, you see how restricted diffusion can be in the central gray matter. Now, what is the diagnosis over here? And it said, this child had progressive problems doing gymnastics, doing sports. So you have here this list of differential diagnoses. So basically, the mitochondrial disorder should now pop up over here because this is an issue most likely related to some energy metabolism disorder. This child indeed had the mitochondrial disorder, and this is a heterogeneous, polysymptomatic, and often multisystemic heart, muscle, organs, and brain disorder, where the neurological signs frequently predominate in the clinical presentation. The mutation affects the structure and the function of multiple or several mitochondrial enzymes. And you know the mitochondria is over here, which is in the cell, and inside of the mitochondria you have multiple enzymes which are responsible for the energy metabolism and the production of ATP, which basically is our most important fuel. You can call them also respiratory chain disorders, a part of it. Mitochondrial encephalomyopathy is reserved for those disorders involving typically the respiratory chain disorder, which you see over here, 1, 2, 3, 4, and 5. The prototype is the Lee syndrome. For sure you know about the Lee syndrome, which was described or named after a psychiatrist who described this first. And it is also known as a subacute necrotizing encephalomyopathy. And many enzymes can be involved, including cytochrome C oxidase, complex 1, 2, 3, 4 deficiency, etc. Interestingly, in Lee's disease, typically the brainstem cells have a mutated mitochondrial DNA. You have multiple forms, neonatal form, late onset form, acute onset form. So depending on when it presents, we will just rather easily define it as neonatal, late, or acute. The later the onset, the slower the progression. Most symptoms, however, die within a couple of years after they have been diagnosed or came with the symptoms. At the moment, you have no treatment available. We just support them. And there is some overlap with thiamine deficiency, so that's why some groups give thiamine or vitamin B1, which can slow the pain a little bit down. The imaging findings are non-specific, and differential diagnosis, again, extensive and include perinatal asphyxia, there we go again, kernicterus encephalitis, and Wilson's disease. Imaging findings, some examples, typically here, this is a chronic case, we see cavitations within the central gray matter bilaterally. Frequently you will see that the vessels which are sitting in there, the white matter or gray matter around those vessels may be spared, as you see it over here. It can also just affect the thalami or show predominantly the infection of the thalami. It's a big variability and non-specificity. 2 more cases to go. This is a case, in the meantime, you know it because we discussed it yesterday. A child with macrocephaly, developmental delay, and seizures, and there's a little bit too much fluid over both hemispheres. So we know non-accidental injury should be considered, glutaric aciduria type 1, Menkes disease, maybe meningitis, maybe dural sinus thrombosis. This is a classical case of glutaric aciduria type 1, was also confirmed. This is a disease which can present in the neonatal time period. It is linked to an inability to break down the amino acids tryptophan, lysine, and hydroxylysine. And it is linked to a deficiency of the glutaryl coenzyme A dehydrogenase, difficult words, in the mitochondria, and this will result in excessive levels of glutaric acid and its derivatives. Now, the accumulation of these products will damage the brain, especially the basal ganglia and the white matter. Secondary carnitine deficiency may develop because carnitine is used to basically to take care of this excess glutaric acid, and this may also be one of the ways how we can treat those patients. At birth, what Zoltan said, Luke also said, the shape of the head, typically macrocephaly. They may be asymptomatic until a metabolic crisis, for example, after an infection occurs or develops. And if they eat low-protein diet and have very few illnesses, it may really take a long time before they present. Infection, never good. Surgery may also induce a crisis. Seizures, dystonia, and choreoacidosis. Mental retardation, dystonia will occur and follow up, and prognosis is poor as soon as the first crisis or the row of crises have occurred. Early diagnosis, again, essential. The acute crisis, you see typically restricted diffusion. On MR spectroscopy, the rather non-specific reduced NS2 aspartate, but you will see some increased lipids. And it may mimic child abuse, which may result in a delay in the diagnosis. That's why diagnosis may be difficult. Blood or urine test for glutaric acid is usually very straightforward. Low levels of carnitine, as said before, may be suggestive. You will do your neuroimaging, siblings should be screened, and treatment is take care, no crisis, take care of a low protein diet, and give carnitine. That can really help. The imaging findings have been well described. There's a paper here in pediatric radiology where they all put together. Typically, you'll see expansive CSF space anterior to the temporal lobes, widening of the Sylvian fissures characteristic, white matter, hypomyelination, delayed myelination, and involvement of central gray matter. Here, out of that article, those white Sylvian fissures, also known as temporal polar arachnoid cysts or cystic lesions, the fluid over both hemispheres, white matter abnormalities, and also central gray matter may be involved. Last case. I'm from Switzerland. That should be a hint. And we described the case already before. Full-term neonate, vaginal delivery, floppy at birth, poor respiratory effort, could be HIE. NICU, apneic events required vigorous stimulation to recover. The child was intubated. Normal chest film. Neurology, hypotonic, posturing, seizures, abnormal EEG. And this child had dysmorphic features, like my previous talk, used clinical information. Tourocephaly, wide nasal bridge, unpalpable testis, bilateral knee contractures, inverted feet, and large cornea. I think Dr. Nadig already knows the diagnosis. I'm sure he knows it. On imaging, we see a bilateral polymicrogyria, and we see an abnormal white matter. We see here the stippled calcifications, unpalpable testis sitting in the inguinal canal, and the very long chain fatty acids are positive, positive, positive. Another kid, this bilateral symmetrical perisylvian polymicrogyria and a very high riding forehead and seizures. So central sylvian pachygyria polymicrogyria is what we see, stippled chondral calcifications, delayed myelination, tourocephaly. Those are the imaging findings, and the diagnosis is not a Miami syndrome. It is a Zellweger syndrome. That's why I showed the Matterhorn, because Dr. Hans-Ulrich Zellweger was from Switzerland, from the hospital where I was trained. It's also known as cerebrohepatorenal syndrome. It's a peroxisomal disorder, what Zoltan said before. The peroxisomes are organelles that contain more than 50 enzymes involved in the catabolism or oxidation of the very long chain fatty acid. That's why they are increased. As you said, elevated plasma, and death frequently occurs in the first years of life. You need an intact peroxisomal function for normal brain formation. Otherwise, you get all these findings, and these findings are complex and characteristic. You can see germolytic cysts, polymicrogyria, hypomyelination bilaterally. And you can make this diagnosis already intrauterine. This is the same patient, follow-up imaging, especially if you know there's a positive family history, you will have a higher, of course, sensitivity. And then the clinical features are so characteristic: facial dysmorphism, broad forehead, hypoplastic nasal bridge, a very large fontanelle, exquisitely well suited for ultrasound of the brain, ophthalmological defects, those calcifications, hepatomegaly, and renal cortical cysts. And depending on when it occurs and the severity, you have a whole group of peroxisomal disorders. Now, my last two slides. There are so many other disorders which can occur, which can present in the neonatal time period where you just don't know it. And this was a case. I just saw the T2 hyperintensity, and I did not know what it was. I asked Andrea Peretti, one of our pediatric neurologists sitting in pediatric neuroradiology, and he said, oh, that's the classical isolated sulfite oxidase deficiency, and he gave me the paper. So it is really worthwhile having a clinician in your group. But there will still be cases where you just don't know what it is. I was so sure this was a glutaric aciduria type 1, only to find out the child is completely healthy and doing very, very well and has nothing. So the more I think, the more confused I get. And in conclusion, always think about metabolic disorders also in the neonatal time period. They may mimic HIE. Rapid diagnosis is essential. Immediate early treatment is necessary to prevent or limit irreversible injury. Simple treatment sometimes may prevent devastating injury. And final diagnosis is also important in those neonates who had died. So push for an autopsy if you have no clue why the child died, that you can counsel the parents adequately.